This program is brought to you by Emory University.
Good morning, everyone. Happy Friday. Welcome to Fellows Conference. This morning we have a presentation by Vardhmaan Jain, also known as VJ, who is one of our first-year clinical fellows in the research track. He came to us from Cleveland Clinic residency, and he'll be talking to us today about Cangrelor bridging.
Thank you, Dr. Kohli. We're going to get started and talk a little bit about Cangrelor bridging, when and how to do it safely. Three learning objectives for today's talk. One is an overview of antiplatelet management post-PCI. Number two, identifying patients who need bridging. Also, maybe those who might be at risk of stent thrombosis. And three, how to do it safely. So we're gonna start ahead with a case. This is someone who I saw in CCU and consults last September. He's a 72-year-old guy with cardiovascular risk factors, Hep C, possibly a liver mass, and multiple PCIs that we're gonna go through. So his coronary history started in 2015 when he was first diagnosed with triple vessel disease, and pretty much every vessel has been stented multiple times at this time, for NSTEMI, STEMI, unstable angina, CTOs, everything, all with drug-eluting stents. And he's been on DAPT with aspirin and Plavix throughout this time. And he came to our clinic to ask, hey, I want to get a liver biopsy for this liver mass. What should I do about my Plavix? Um, but most notably, when he came to us in November of 2020 or September of 2024, at this time last year, he had stopped his DAP to get his wisdom teeth extracted, and he unfortunately had a STEMI and had an LED PCI. So we knew that he's someone who's high risk for stent thrombosis once he stops his DAP, no matter how long out of his PCI he's been. So given that, we're gonna go forward with his labs a little bit. As you can see, LDL was at go. His diabetes wasn't super well controlled, and he had some CKD. As far as his meds, he was on good meds. He was on DAP, statin. He was on Repatha and Jardiance, losartan, in fish oil, and insulin. Um, Focus physical exam was pretty unremarkable, and his last echo showed a preserved EF and some diastolic dysfunction, but no significant wall motion abnormalities. So going over his anatomy, as we'd expect, everything is kind of diffusely stented. As you can see, the RCA has mild diffuse ISR throughout. I'll play it again for you guys. Has some distal disease, but nothing that needs to be revascularized prior to any major surgeries. And then the left system, again, diffusely diseased, almost like a metal jacket, has some ISR throughout the vessel. Distal vessels are more sinuous, but no significant proximal occlusion that needs to be emergently revascularized. Um, and then this is another shot that shows the LED better laid out. But as you can see, it's large wraparound LED, no significant lesion, but diffusely stented. Um, and then this is a spider view. So echo quality wasn't great, but you can have my word for it. EF was preserved. No one more abnormality. So here we are. So the question, and his EKG, sinus rhythm, right bundle, left anterior fascicular block, but no STT changes. That been his rhythm for many, many years. So knowing what we know about him, how would you manage his antiplatelet therapy prior to his liver biopsy? And that's going to be the focus of the starting point of our talk. Um, so, learning point number one: overview of management of antiplatelet therapy post PCI. So, a primer about platelet physiology. So, as you know, human platelets have a number of receptors, but the most important ones that we care about are P2Y12 and GP2B3A. There's also P2Y1 receptor that causes transient platelet stimulation, but P2Y12 is the big player that causes thromboxane release, platelet constriction, remodeling, eventually activates GP2B3A, and that's why P2Y12 receptor inhibitors are the mainstay of pharmacotherapy for management of post-PCI patients and to prevent thrombus formation. Aspirin inhibits thromboxane A2, and so it's a more distal inhibitor. And finally, more recently, GP2B3A receptors have come into play. that also inhibits some stages of platelet aggregation. So with that, this is not this one, but the most recent guidelines on coronary revascularization. And as you can see, expectedly, level 1 level of recommendation for everyone to get aspirin loaded and maintenance post PCI, everyone to get a P2 white valve inhibitor loaded and maintenance post PCI, and even so in stable ischemic heart disease undergoing PCI. Now, there's weak evidence to support that ticagrelor and prasugrel might be more efficacious in patients with high thrombus burden, those with prior stent thrombosis, and those presenting with ACS. And this evidence largely comes from the Plato and the Triton-TIMI 3 trial that showed that prasugrel or ticagrelor versus Plavix might have lower risks of stent thrombosis, MACE, especially in an ACS setting. But the problem was that those were the only trials that as such showed those benefits. And also um, we know now from Dr. McDaniel's talks that Plavix is a prodrug that needs CYP2C19 to be metabolized into its active form, and about 25 of the population does not have that enzyme. So could it be that Plavix is not efficacious, or is it that Plavix is just not being metabolized? Who knows? But regardless, some providers prefer ticagrelor and prasugrel, which is reasonable. Um, but as you know, there's some contraindications to using prasugrel and ticagrelor. Most notably for ticagrelor, if somebody's had brain bleeds or has bad livers, you should avoid them. For prasugrel, if somebody has TIA or ischemic stroke, you should avoid them. And that's basically based on the observations from those trials that showed higher rates of these complications with these drugs. And more importantly, if somebody needs triple therapy, like if they have AFib and DVT, we should try and avoid prasugrel and ticagrelor. I know people don't always abide by this, but I think if you're being conservative in our practice, we should be mindful about that. Moving on, we're going to switch our gears into IV antiplatelet agents. And as we know, Cangrelor is a P2 white valve IV antiplatelet agents, and these three are GP2B3A IV inhibitors. And as you can see, the pharmacological properties, Cangrelor is really fast on, fast off, whereas the GP2B3A inhibitors need like more longer infusion times and wear off in about 18 to 24 hours. That's something that we should be mindful of whenever we're using these agents, and that's going to affect our decision making in the bigger spectrum. So, Cangrelor, fast on, fast off, P2 autoimmune inhibitor. That's the take home message. The most recent guidelines say that in platelet naive patients, Cangrelor is a reasonable alternative to Plavix, or patients who can't take PO meds. It's reasonable to use Cangrelor instead of Plavix. The evidence for Cangrelor comes from the meta-analysis on Champion trials that was like in the early 2000s that showed Cangrelor is maybe even better than Plavix in pooled analysis. So that's pretty much it. So that was learning objective 1. Learning objective 2, identifying who actually needs Cangrelor, or a weird way of saying who is at risk for stent thrombosis. So stent thrombosis is an acute occlusion of a stent that is almost like a thrombus formation, usually presents like an ACS and or sudden cardiac death, and it should not be confused with ISR or in-stent restenosis, which is a more indolent course. It's almost like plaque forming in the stent slowly, so it's generally going to present with angina rather than acute stent thrombosis. And based on timing, stent thrombosis can be all the way from acute to very late, as you can see. And acute and subacute are generally more commonly encountered in clinical practice, and that's why we're more concerned with DAP in the first month out of a PCI, and less. And as you can imagine, very late stent thrombosis is not that common. It's like less than 0.5% of all post PCI patients, and we don't have a great understanding why it happens. But as you can imagine, our patient was the focus of this bracket, very late stent thrombosis. Why it's happening, how can we prevent it, how can we let him have his surgeries as needed. So a little bit more about stent thrombosis. As you know, any procedure or like complication has patient, lesion, procedural, and post-procedural risk factors. And it's kind of a loaded table, but I'd like you to focus on important factors for late stent thrombosis, most notably patient stents that are not completely endothelialized and there's residual stent material, delayed healing, Most interestingly, brachytherapy has been identified as a risk factor, and that's important because we're doing brachytherapy for a lot of ISRs again. And brachytherapy actually just inhibits muscle proliferation, but also prevents endothelium to grow back. So you can imagine if the endothelium is not growing back, the surface remains exposed. So while you're preventing ISR, you're increasing the risk of stent thrombosis. So a lot of my friends who are going to go into interventional and CHIP fellowships should be mindful of this when they do brachytherapy. And also people who've had multiple stents. Unfortunately, drug-eluting stents have higher risk of stent thrombosis compared to bare metal stents, and some people think it's because people form antibodies to the component of the drug-eluting substance itself. Um, and also, some people believe, for unclear reasons, discontinuation of DAP very late into the process can also cause stent thrombosis. Stent deploying factors, so stents that are not completely opposing the vessel wall have any gaps. Stents that break down obviously can cause stent thrombosis, but all of us are really good doctors, so we're not going to do that. And so, in our patient, important things that we thought could be contributing was delayed healing and incomplete endothelialization, and discontinuation of discontinuation of antiplatelet therapy could be contributing. And this is a nice graphic that depicts the mechanisms of stent thrombosis, late stent thrombosis. So as you can see, delayed endothelialization leaves the stent struts uncovered and leaves them at risk of forming a thrombus. Um, Neoendothelialization, so plaque forming within the stent, and then the plaque can have rupture, almost like a STEMI of a new plaque inside the vessel wall. Some people can form antibodies to the substances of the stent and have hypersensitivity reactions. This can be delayed, almost like a very delayed rejection of the stent. Improperly positioned stent leaving gaps in, and fractured stents where thrombus can form. So, a brief overview of stent thrombosis. So, that was learning point number two. And finally, finding out how, if now that we know that Cangrelor can be useful in bridging, and we think this patient might be at risk of stent thrombosis. Our team decided that, hey, this guy would benefit from Cangrelor bridging, so we should bring him early before the liver biopsy and get him bridged. Now the question is, how do you do it safely? And the evidence for that comes from Bridge trial. This was an early mid 2000s trial that was done really really well. I'd say very scientifically, and was focused at answering a very specific question that can actually bridging with Cangrelor inhibit platelet activity? That was the question. No clinical outcomes is can it inhibit platelet activity? And with any new drug, as you would imagine, you want to do a dose finding study, because without knowing a safe dose, you can't just like slam people with high dose blood thinners. So they did a dose finding study. They did a phase 1 10-patient open label study where they studied the pharmacokinetics of the sample population, and they found out that at 0.75 microgram per kg per minute infusion rate for 2 days, they achieved effective platelet suppression, and that's the dose they chose for the trial. And the phase 2 was a large, double blind, and randomized controlled trial of 240 patients. These were patients who they thought were at risk of stent thrombosis. So there were patients who had stent thrombosis, patient who had PCI recently, patient who presented with ACS but needed cabbage but got unfortunately loaded with Plavix. So all those patients were enrolled. So really good representation of patients. And these were patients who were undergoing cabbage. So really major vascular surgery with high risk of bleeding. And they randomized them 120 to get Cangrelor and 120 to get placebo after stopping Plavix 3 to 5 days before the surgery. And the primary efficacy endpoint was to see effective platelet suppression as measured by point of care testing or platelet reactivity units. And a cutoff less than 240 has been reliably accepted as suppressed platelets. And it's a very interesting test because it's very easily available in point of care in most cath labs, almost like an activated clotting time, where you can see platelet count pretty easily. So it's not that hard to find. Verify now is something that we've seen in Emory labs. So I think it's not something to be mindful about in our practice. And the safety point was obviously major bleeding, because if you're giving a blood thinner, is it increasing the risk of bleeding? That was the question they asked. And like I said, Cangrelor had to be infused for at least 2 days at that dose, and it had to be stopped anywhere between 1 to 6 hours before surgery. And the platelet sample activity was checked right before the incision was made for the surgery. And obviously, they were successful in showing what they wanted to show. So compared with placebo, 98 or 99% of the people had effectively suppressed their platelets compared with only 19%. So what we're normally doing in clinical practice is protecting only 20% of the people, stopping Plavix for 5 days and sending them to surgery is not the best move in patients who are at high risk for stent thrombosis. And also, there was no increased risk of bleeding, 11.8% versus 10.4%. So and it's important to note that in that trial they were very conservative. They infused Cangrelor slowly. That's why it took 2 days. But Cangrelor can also be safely infused at almost 8 times faster rate and achieve peak half life in 2 hours if you need to be more emergent. And it wears off really fast. Its half life is 5 minutes. So in 1.5 hours, theoretically, you should not have any platelets left. You should have platelets back to normal. But the problem is, like we know, there's a lot of genetic variation in Plavix metabolism as well. So it's possible that somebody's half life could be longer or shorter. So you don't really know when platelets are coming back unless you actually test for them. And so, from what we know, a successful bridge would look like suppressing platelets throughout the period when the patient's not on any meds, and then have the platelet activity come back to normal just before the surgery so that it can stop procedural bleeding. And after the surgery is done, you restart platelets. So that's a successful bridge. Um, and so coming back to our case, our guy was brought in, and we started, um, we know that he'd had stent thrombosis previously. So we said, okay, you should get Cangrelor. And we talked to the surgeons, we talked to his hepatologist, we talked to IR, like, is this biopsy important? How do you actually think this could be cancer? Like, can he avoid the biopsy? But eventually, everybody decided he should get the biopsy, and IR was driving the show, and we were helping them with Cangrelor bridging. And the IR and pharmacy team sort of decided that we should bridge him for 3 days, and then stop it 6 hours before biopsy would be taken. So that night, he was in the CCU, and he was tolerating Cangrelor well, and he was supposed to get his liver biopsy at 9 o'clock. So the drip was instructed to be stopped at 3 o'clock, and everybody did their part. But around 6 o'clock, we got a call from the CCU resident. The patient's having some chest pain, and we gave him nitro, but he's getting hypotensive. So I said, hey, can you take an ECG and send it to me? And lo and behold, he is having a STEMI. Uh, Unfortunately, 15 minutes later, by the time we got there, patient had already gone into VTRS that lasted 2 hours, degenerated into PRS, and he could not get ROSC. And we did everything we could. We even pushed cath alteplase, and but it really didn't work. And unfortunately, our patient ended up dying. So that's pretty much the outcome of that case. And what we learned from that case was that it was a very challenging situation, because this patient was at high risk for stent thrombosis after stopping Plavix, but also he could have died from the liver cancer that was not diagnosed. Was it actually liver cancer? We'll never know. But experts thought that he should get the biopsy, so we were doing our part. Um, More so, what could we have done differently? So I thought, looking back into the evidence, that once you stop the Cangrelor drip, you can check platelet reactivity every hour. And if the platelet reactivity is coming back really, really fast, you need to restart the drip and talk to your surgeons like, hey, he might be too risky to take to a procedure, or stop the drip only for half an hour before the surgery, and then restart it as soon as he's back from the surgery. And these kits are pretty easily available and point of care assets. So I think if you're doing this, and a lot of us might be doing this in a CCU setting, or like interventional cardiologists who are sending our patients for high risk non cardiac surgery, we should be mindful because we will encounter this situation. And the last thing I noticed was that nobody actually did any enzymes checks on a CYP2C19 levels. Because what if he had a mutation that rendered him less responsive to Plavix, and we could have switched him to prasugrel Ticagrelor? But those are just thoughts to keep in mind whenever such a situation arrives. Um, I think that's all I have for you guys, and I'm open to comments and questions.
Thanks, VJ, for that great presentation. I'm curious, would there have been any role for like a 2B3A or IV heparin for this gentleman as well?
Yeah, so that was a good question because people thought, why do you need Cangrelor? So they've actually tried those agents, and heparin acts on a different pathway compared to platelets. It's actually acting on the anticoagulation cascade. So it paradoxically increases platelet activity and can increase the risk of thrombus formation. So a pure blood thinner is not a good option for bridging. And for 2B3I, they were mostly studied for high thrombus burden in the pre antiplatelet agents era, like early 90s, and they haven't been studied when coupled with Plavix for this indication. They take 18 to 24 hours to wash off, so it's not easy to bridge someone and then hold it for another day. So it's not like Cangrelor, and also they're really potent. So high risk of bleeding made an efficacy study for a dose finding study to be done safely impossible. So even though theoretically we want to do them, they have a lot of pharmacological properties um, that make them really difficult to be candidate for bridging.
Thanks. Any other questions or comments?
I think Shannon, Dr. Walker asked which vessels was stented, but everything, like Dr. Kumar said, everything was stented multiple times, and the last PCI was more than 17 months ago. So we really don't know why he was having delayed stent thrombosis, but he was one of those rare patients that just has stent thrombosis every time he stopped Plavix.
I guess the other question is, did it really have to be stopped like because they stopped it 2 hours before the biopsy, right? Could it have been an hour before, or even like as he was being wheeled to the biopsy suite?
Yeah, I feel like that's the biggest thing that we could have done differently. So I think they actually decided to stop it like 6 hours before, and that decision came from the person who was doing the biopsy and in conjunction with pharmacy. And I think that part was a really big gray area. Even in the trial, they stopped it like 1 to 6 hours, and there's no clear evidence to support how do you come up with this time frame. I think if you're being very objective in our data points, then just checking for platelet function every hour after stopping the drip and seeing if they're rising too fast, then just restart the drip. That would have been a safer way to approach this rather than, kind of turning a blind eye after we stop it for 6 hours and hoping that platelets don't come back.
So Vijay, what are the patients that you can think of whom you can identify who are at risk of delayed healing following PCIs? Because we do a lot of PCIs, put a lot
Yeah.
of stents, but who do you think are at the highest risk?
I think, yeah, Dr. Kumar, that's something that will come up a lot. I think patients who've had like multiple PCIs, patients who've had complex lesion PCIs, like bifurcation PCIs, and patients who've had, like I kind of mentioned a little bit about this, who've had brachytherapy for ISR, because brachytherapy is targeted at suppressing all cell growth at the stent level. So it also suppresses endothelialization. So they won't have stent healing. So I think those logically seem to be the people who would be at risk for delayed healing. But you're the expert, so I'd love to hear your thoughts on that as well.
Yeah, I agree with you. Stent length, overlapping stents, especially overlaps, brachytherapy definitely, multiple vessels. That's the other big risk as well. I think those are the main factors that come into play in these kinds of cases. I'm sure the SIP level would have made a big difference here because, yes, you have Plavix resistance, but we know that that's not the problem. The problem was the Plavix was stopped. So
Yeah, exactly. So
I'm not sure how that plays into it.
yeah.
Just a quick question. Do we have any data on doing these types of procedures on dual antiplatelet?
So liver biopsy, no, there was no evidence of no literature to suggest the safety of doing a liver biopsy on Plavix. I tried to look that up as well. And I feel like even if there was, this is something that's very operator dependent. You know how you see a doctor for even GI when you see, like I had a friend who is a GI fellow here and he's like, oh, should we stop Plavix for polypectomy? I'm like, theoretically, you can possibly do it on it, but you're the person who does it. And so as at Emory, GI doesn't like to do polyp removals on Plavix and they ask them to stop it. So I feel like this is pretty operator and institution specific and there's no guidelines to guide them. So you just have to work with your surgeons when this comes up.
Cool. Thank you.
Thank you.
PJ, hey, this is Rob Wilson.
Yeah.
So in interventional clinic, when we get the cardiac clearance forms,
Yeah.
the second question always is about the antiplatelet therapy.
Yeah.
If patient got a stent. So first of all, are they clear for surgery? And then what about antiplatelets? So you did a great job outlining who is high risk, and also a great job on the temporal relationship as far as risk of stent thrombosis. For someone who's not high risk, let's say someone who had focal RCA stent 10 years ago. We usually tell them we want them to stay on aspirin, and oftentimes surgeons will. But if it's something high risk, probably if it's a brain surgery and they're 10 years out from a focal RCA, that's pretty low risk. We sometimes will tell them and say, listen, if you need to stop the antiplatelet, just stop it, right? Risk is low. I mean, what are your thoughts? And I'd be curious about Dr. Kumar's thoughts as well about just say, listen, this patient's low risk for stent thrombosis, high risk for bleeding if they stay on it, right? Because they're in brain surgery or whatever. Do you have any of your research or you have any thoughts about that?
That's a great question. Actually, it's a very interesting time to be giving this talk. My dad's had a colonoscopy yesterday, and he had a stent like 6 years ago, just one RCA stent, like he said. And but we kept him on DAP because we're not good doctors. But he said, "Oh, you need to stop your Plavix," and my dad was like, "What's the risk of it?" So we did a deep dive into this, and from observational literature, obviously, because this is something you can't do in a randomized fashion. For every year after year one of PCI, the risk of stent thrombosis drops, and it's about 0.4 to 0.6%, like at about 5 years out. So you can tell them like, hey, the theoretical risk exists, but it's like less than 1% of this happening. But you really need this procedure, so you should still get it, knowing that there's a very, very, very small percentage chance of this happening. I think that's how I would put it if I was in clinic.
Yeah, that's well stated. That's what we usually tell our patients. The risk is low. It's not zero.
Yeah.
But the ACC and the AHA they're very clear that when you evaluate this risk, the risk of bleeding takes precedence over the risk of a thrombotic.
Yeah, exactly.
And so it's not especially especially for people who are not necessarily high risk. It's not exact science, but it's really low risk.
Yeah. Thanks.
Since you sought my opinion, I think there's a lot of things that play into it. I think one of the things that goes into it is the size of the blood vessel. If you have a nice big 4-0 stent, there's a good chance that it's going to heal. There's plenty of flow there, less chance of stent thrombosis. If you have a small little 225 dinky stent in a small vessel, probably, and it's a long 225 stent, especially like a 225 by 33 stent or something like that, your risk of stent thrombosis is probably going to be higher. Delayed healing is probably a higher risk in that vessel. That vessel is more likely to get blocked. Of course, you can make an argument. Big deal if a 225 little branch of a dinky OM get blocked. Big problem if a 4 millimeter left main or LAD gets blocked. So there's also that flavor that comes into it. I think the longer you are away from the event, the safer it is. That's definitely something that comes into play. A single stent is probably safer. Shorter stents. Yeah. So those are the things that come into play for sure.
Yeah, those are great. Very helpful comments, Dr. Kumar. We here at Emory, we're able to communicate with the surgeons, the anesthesia team pre-op, and most of the time surgeons don't like to operate while patients are taking clopidogrel, but oftentimes they will if they're taking aspirin. So we just say, change up to aspirin and do the procedure, do the surgery. It's just if it's real high risk, certain ones they just aren't comfortable doing it, and that's we sort of have to have this whole decision tree discussion like Vijay outlined.
Yeah, we got stuck in a catch-22 with this patient because, I brought up all of these issues and they were like, no, we are not going to do it on aspirin. We are not going to do it on Plavix. And we are going to stop it for 4 hours. That's what pharmacy says. I'm like, well, 2 hours is probably fine. No, we're going to stop it for at least 4 hours.
Right.
So at that point, I was like, why did you all not do the biopsy? We actually thought about that too. No, it could be cancer. We got to do the biopsy. All right. Yeah.
Sometimes there's no right answer, right?
Yeah.
Stan Sherman, that cath, was that recent, right before this whole thing happened? Because it sure looked pretty clear.
Yeah, it was October 2024. It was less than 4 months before his when he presented to the hospital. I'm blanking on the exact date, but it was about 4 months before he came to clinic.
Yeah, and and in retrospect, you wonder if this mass had caused patient to have a hypercoagulable state.
Yeah.
That maybe he did have cancer, or maybe he was hypercoagulable, and and he'd had so much problem that he had brachytherapy and everything else in the past. You wonder if, in retrospect, you wonder if he could have been tested for some sort of hypercoagulability.
Yeah, definitely.
Well, there's a lot wrong with this gentleman. He was a very favorite and close patient of mine. Was a chaplain in in Vietnam, and was at an air base and was heavily exposed to Agent Orange. And therefore, for those of you who don't know this, Agent Orange is and those of us who work with veterans know this for a fact. Agent Orange is a very, very high risk factor for atherosclerosis and for multiple malignancies. So he has had multiple malignancies over his lifetime, and he has survived all of that. And he has chewed through stents like nobody's business. You stent the LAD, pretty much proximal and distal to it, there's be restenosis, and we've done all kinds of stuff like off-label peripheral drug-coated balloon in his circumflex to avoid putting more stents. He was referred for cabbage a long time before all of this. He was turned down for that. He had very calcified arteries. He was one of the first people in the country to be treated with orbital atherectomy for his circumflex. So, I mean, there's a very long history of severe aggressive coronary artery disease in this patient.
Mm-hmm. Mm-hmm.
Well, if there aren't any further questions or comments, we can go ahead and wrap up. Thanks again, Vijay, for a great presentation and everyone for a great discussion.
Thank you, everyone. Thank you, Dr. Kohli.
The preceding program is copyrighted by Emory University.